Hello, everybody, and welcome back. We now move on to our 10:45 session titled The Medical Management of Metastatic Colorectal Cancer with the amazing Dr. Sharlene Gill. Dr. Sharlene Gill is a professor of medicine at the University of British Columbia and a medical oncologist specializing in gastrointestinal malignancies at BC Cancer, Vancouver. She received a Bachelor's of Science in Pharmacy and an MD from the University of British Columbia in 1996, followed by residencies in internal medicine and medical oncology. Dr. Gill subsequently completed a fellowship in GI oncology at the Mayo Clinic and has a master's of public health from the Harvard School of Public Health. In 2017, she completed an MBA from the Kenan Flagler School of Business at the University of North Carolina. She's actively engaged in education and research with over 120 peer-reviewed publications and book chapters to her credit. Dr. Gill serves as the chair of the Canadian Clinical Trials Group, GI Disease Site Committee, and chair of the UBC Department of Medicine Mentoring Committee. She is the editor-in-chief for Current Oncology and is the president of the Canadian Association of Medical Oncologists. Her TED Talk in 2022 on how to flip script on cancer delivered her passion for patient advocacy and empowerment. I will also note that Dr. Gill is also a respected member and co-chair of CRAN's Medical Advisory Board. Thank you very much, Dr. Gill, for being with us today, and I'm happy to pass it to you.
Thank you very much for the invitation and very kind introduction, and really happy to be here. I'm just going to share some slides for the presentation. As Chris mentioned, I'm a medical oncologist. I'm based out of BC Cancer in Vancouver. I've been asked to spend the next 45 minutes or so talking about the medical management landscape of the treatment of metastatic colorectal cancer. And looking at the program for the summit this year, I see various aspects of management being discussed, both in terms of local, regional, surgical options. We're going to focus on the systemic therapy option, that's sort of the medical oncology piece in the treatment of patients with advanced disease. And I know for those people who are listening live or will be listening to this after the fact that this audience includes, people who have a lived experience and of varying levels of expertise and understanding of the landscape. So I'm hoping this will all kind of come together and will resonate. But the intent is really to kind of focus on, the Canadian landscape as well in terms of what is available in Canada, but we're going to speak broadly about the evidence to support our current options. I'll start by saying that, when we talk about advanced disease in colorectal cancer, what we're typically referring to is stage 4 colorectal cancer, and this includes patients who have distant metastatic disease, and typically, that does not mean it may not be resectable. So as I mentioned earlier, I know there are talks talking about the surgical management, but my discussion is going to focus on those situations where systemic therapy, sort of chemotherapy or immunotherapy, targeted therapy, is the mainstay for treatment. Recognizing that there are going to be patients who have, what we call oligometastatic disease or limited sites of metastatic disease, where local and regional treatment options are going to be considered. It's also, in terms of level setting, in 2026, we can't really talk about metastatic colorectal cancer without referencing the fact that it is not a single disease, and we recognize that there are many molecular subtypes within colorectal cancer that not only define behavior, like what we talk about in terms of prognosis, but also can predict response to treatment. The notable ones that we're going to be referring to in this talk are the ones that are sort of the most actionable and the most common. So the most common alteration that we see are RAS mutations in this, what we call the MAP kinase pathway. Those are observed in 40 to 45% of patients with colorectal cancer. BRAF mutations, which also is kind of, I will say, a cousin kind of linked to the RAS mutations on that same MAP kinase pathway, are observed in about 8 to 10% of patients. We are going to spend some time talking a bit about mismatch repair deficiency, which is more of a phenotype arising from a loss in control mechanisms for mismatch repair that's observed in the metastatic disease, observed in about 3 to 5%. But these other little bubbles that you're seeing are also emerging targets of interest, and I'll briefly allude to them as well. We also recognize that not only is colorectal cancer defined by molecular subtypes, but anatomy also matters. And historically, we have, from a treatment perspective, separated colon versus rectum. But I think what's recognized more, particularly within the last 10 years, is that there is kind of a continuum in terms of changes in the genomic alterations that are seen based on site of disease. So, right-sided cancers typically, and those are cancers that sort of involve the ascending colon and the transverse colon up to the point of the splenic flexure, typically are more commonly associated with mismatch repair deficiency, are more commonly associated with RAS and BRAF mutations, while left-sided cancers, so cancers from the descending colon, sigmoid, and rectum, more commonly have like P53, APC mutations, and these do inform behavior, so prognosis, but also can inform treatment. And then finally, in terms of level setting, just to remind ourselves, like as a medical oncologist, these are the tools, if you will, or the treatment options that we have that we exploit in different settings to try to maximize the clinical benefit. And in metastatic colorectal cancer, when we talk about clinical benefit, we unfortunately typically are not talking about cure. We're talking about disease control. And when I have conversations about what treatments do we want to think about, or what treatment may be considered in sort of a subsequent line of treatment, it's really important to balance what is the goal of care here, and is this option that we are thinking about going to meaningfully achieve an improvement in survival, like how much time we can gain, and while maintaining quality of life. So can it offer the option of not only living longer, but also living better? So let's talk about sort of the treatment options for stage 4 disease or metastatic disease. These options are, as I mentioned, are not a linear sort of one size fits all, and it is informed not only by the molecular characteristics that I was referencing earlier, but obviously by our patient's characteristics. So things that will influence how we may tolerate treatment, our expectations from treatment. And these do include age, it does include comorbidity, it does include how well we are feeling, or our functional status, or what we call our performance status. It includes characteristics about the tumor itself, separate from the molecular phenotype, like what I talked about, genotype, sorry, what I talked about, like in terms of, is it resectable? What is the location of the primary tumor? And probably most importantly, it's really, what is the patient's preference? What do patients want? What do they value? What is the risk tolerance and the trade-offs that may have to be weighed in thinking about treatment, including impact on quality of life, time on treatment, and side effects or toxicity. So that being said, a big part of the treatment decision making is influenced by molecular subtypes. And so in 2026, what we call the first line options in someone who's previously untreated for metastatic colorectal cancer, that is heavily informed by really 3 molecular markers: RAS, BRAF, and MMR that I referenced before. And I won't go into the specifics too much. I'm going to talk about this a bit more, only to say that even as we talk about the emergence of targeted treatments, chemotherapy is still a really important backbone, typically in combination with all of these approaches. The one exception is deficient mismatch repair or metastatic colorectal cancer, where thankfully immunotherapy has really emerged as a target. And once we are no longer benefiting from first line treatment, we talk about post progression or subsequent line options. And And typically, we are looking at what we haven't used in the first line and seeing if there's an opportunity to use that now in a subsequent line. It's fair to say that the approach is to use our most tailored and effective treatment option early as possible. So really that first line treatment decision making is probably the one that we spend the most time on, making sure that is tailored to both the patient and their tumor molecular profile. We published these sort of recommendations about 4 years ago in 2022, and it was really to try to provide a consensus within Canada of what biomarkers do we need when we are making that first line treatment decision. And mission critical was we must have RAS, BRAF status, and mismatch repair status, because those directly impact which treatment we will choose in the first line setting. RAS and BRAF, and I know you just had an earlier talk about biomarkers, so this is probably a refresher, but RAS and BRAF these are done by molecular testing. Mismatch repair is done by immunohistochemistry or immunostaining. There are also biomarkers that may not in 2026 directly inform our first line treatment options, but we know they may influence options for later lines of treatment, and those include NTRK and HER2, which I will mention briefly. I'm going to spend a little bit of time kind of talking about mismatch repair because it is really, again, in the last 5 years, has totally changed. The treatment landscape has totally changed in this subset of patients. So typically, when we think about sort of cancer development in colorectal cancer, historically, when I was in med school, like 25 years ago, 30 years ago, actually, this is 30 years, I graduated in 1996. Chromosomal instability was what was taught, that cancers arise from sort of successive hits to the chromosome that may result in promotion of what we call proto-oncogenes and suppression of tumor suppression genes. And what has subsequently been discovered is there are about 15% of colorectal cancers that arise from a mismatch repair deficiency, sometimes referred to as high levels of microsatellite instability, really the same thing depending on how it's been tested. And historically, this has been important for the perspective of Lynch syndrome ascertainment, because we know that these mismatch repair deficiencies can be acquired from a germline mutation. But in many cases, they can be sporadic. As we get older, we may have a higher risk of acquiring deficiencies in mismatch repair. What's germane to our discussion today is that tumors that have high levels of microsatellite instability and/or have deficient mismatch repair tend to have high tumor mutation burdens. And tumors that have high tumor mutation burdens tend to respond better to immune therapy. And so this became first apparent in 2020 with the publication of a trial called Keynote 177 that looked at the benefit of pembrolizumab, which is also referred to sometimes as a PD-1 inhibitor, compared to standard of care chemotherapy in patients with deficient mismatch repair metastatic colorectal cancer. And in the first line setting, it demonstrated a very significant and clinically meaningful improvement in progression-free survival and a trend towards improvement in overall survival. But it was so clear that this was the right treatment for these patients that really became the standard of care very quickly. More recently, there has been data to suggest that combination immunotherapy, so using a PD-1 inhibitor, in this case, nivolumab, similar to pembrolizumab, and adding in something called a CTLA-4 monoclonal antibody called ipilimumab, or the combination of nivo-ipi, which was already widely used in other cancers that respond to immune therapy, was shown to be better than chemotherapy and subsequently better than just one drug, nivolumab, in the CheckMate 8HW trial. And this is also now a Health Canada approved indication in the first line setting and available currently through an access program, but soon to be publicly funded. So nivo-ipi is another option that is now available for patients with deficient mismatch repair metastatic colorectal cancer in the first line setting. I mentioned that the most common alterations that we see molecularly are RAS mutations. And we know that RAS mutations are important because rather than predicting response to a particular treatment, they actually identify patients who are not going to benefit from a class of drugs called EGFR inhibitors. And multiple studies have shown that when we use drugs like cetuximab or panitumumab, whether alone or in combination with chemotherapy, that benefit is primarily seen in patients whose tumors do not have RAS mutations, so what we refer to as RAS wild type. Um, BRAF is, if we look at on this diagram on your right along that MAP kinase pathway is downstream to RAS. BRAF mutations are seen, as I mentioned earlier, in about 10% of patients. Historically more common in the right side, tend to have a different behavior. They tend to be more likely to spread to the lining of the abdominal cavity or the peritoneum, tend to have a higher risk of brain metastases. And they also are unlikely to respond to an EGFR inhibitor. What was apparent, in the, sort of a decade ago was that patients with BRAF mutations unfortunately do not respond as well to sort of standard chemotherapy or chemotherapy plus bevacizumab compared to patients with BRAF wild type tumors. And in fact, these tumors have a behavior that really portends a worrisome prognosis. BRAF inhibitors have been used in other cancers like melanoma, where we see BRAF mutations, but in colorectal cancer, using a BRAF inhibitor by itself was not shown to be helpful. And it really wasn't until this trial, which was published in 2019, the Beacon trial, where the use of a BRAF inhibitor in combination with an EGFR inhibitor was shown to be beneficial. And this is a sort of a steady schema. When this trial was designed, there wasn't enough information to study this in the first line setting where you're going to replace standard of care chemotherapy. So the study was done in patients who'd already received standard of care chemotherapy and were what we call second line and beyond. And they compared chemo, a different type of chemo, second line chemo, to encorafenib and cetuximab. And in the blue box, there was a third arm of actually using another targeted agent with a combination called a MEK inhibitor that subsequently wasn't found to be additionally helpful. The goal was to see, can survival be improved with encorafenib and an EGFR inhibitor, in this case cetuximab. And indeed, they did see a survival benefit and a progression-free survival benefit with a median improvement in overall survival of about 4 months. This became the standard of care in the second line setting because of the Beacon trial. And so for patients with BRAF V600E mutations who have received chemotherapy in the first line setting, encorafenib with an EGFR inhibitor is recommended in the second line setting. More importantly, I think, and probably of greater interest, is that we now have data of using a BRAF inhibitor combination, encorafenib and cetuximab, in combination with first-line chemotherapy that just came out last year called the Breakwater study. And Breakwater was really kind of, once you've seen this benefit in previously treated patients, can we use this earlier? To my comment about we want to be able to tailor the first-line treatment in the most effective way possible. So Breakwater compared first-line chemotherapy in patients with previously untreated BRAF mutated metastatic colorectal cancer to this experimental combination of encorafenib, cetuximab, and chemo. In this case, it was FOLFOX chemo. And they also had a third arm of what about encorafenib, cetuximab alone, or the Beacon regimen. And what was demonstrated from Breakwater was a clear benefit for the combination of what EC and chemo, encorafenib, cetuximab, and FOLFOX, versus chemo alone. And it's important to note that the chemo alone arm included like 40% of patients who had triplet chemo, what we call FOLFOXIRI or FOLFIRINOX chemotherapy. So this was a aggressively treated standard of care arm, and compared to that, using FOLFOX plus encorafenib cetuximab significantly improved the time to progression. And more importantly, that translated into a significant improvement in overall survival, where we now saw a doubling of the median overall survival with the use of encorafenib, cetuximab, and FOLFOX. There has now been subsequently data to confirm similar efficacy in a smaller cohort with FOLFIRI. So that may also soon become an option. 5-FU irinotecan as a first-line doublet in combination with encorafenib and cetuximab is also going to be an option in this setting. Um, Responses were also greater. Obviously our primary endpoint is often focused on survival, but tumor shrinkage matters. 66% response rate with the breakwater combination compared to 37% with standard of care chemotherapy, and these responses were typically longer lasting. So breakwater is also, that regimen is also now Health Canada approved, recommended for funding, and will be a publicly funded option, bridged by a manufacturer patient support program. So there is access to this treatment at present. And so, it's interesting. I reflect sometimes on the fact that when I first started treating patients with metastatic colorectal cancer, over 25 years ago, it was a kind of a one size fits all paradigm, and we primarily kind of had 5-FU based chemotherapy. And that landscape is now more complex and more tailored, and that has certainly translated into incremental improvements in how long people are able to live, even with unresectable metastatic colorectal cancer. Moving on to kind of what happens, after we have um, achieved the most benefit we can from our frontline treatment options. As I mentioned, we sometimes struggle with the use of lines of treatment, but once we've progressed on first line treatment, we then go back to, well, what haven't we used that could be a benefit in this setting? And so this kind of second line treatment will be like, if we used 5-FU and oxaliplatin in the first line, can we use 5-FU irinotecan in the second line? Those are the kinds of discussions we'll have. And again, balancing toxicity and suitability. If there was a targeted treatment we didn't have a chance to use in the first line setting, can we use it in the second line setting? But commonly, we will eventually arise in this sort of space that has been referred to as refractory metastatic colorectal cancer. And refractory is a moving target. It really depends on the options that are available. But it really is referencing the fact that when we have exhausted our standard chemotherapy, and there's like the three main ones, 5-FU, irinotecan, oxaliplatin, and have exploited our known targeted treatments that are supported by, what we call level 1 phase 3 evidence that has demonstrated a survival benefit. We then kind of look to, well, what can we do? What can we offer next? Recognizing that in tumors that have been received more and more treatment, what we more commonly can see is disease control. We less commonly see shrinkage, but we more commonly see disease stabilization, potentially translating into a benefit in terms of survival. So I'm going to go through some of these because I think probably these are the questions I get most from patients, is like, the what's next option. And I'm going to sort of navigate this discussion using the European Society of Medical Oncology, or ESMO guidelines, because they actually nicely reflect what is supported by the best available evidence. And I'm going to start with talking about trifluridine tipiracil, also known as Lonsurf, in combination with bevacizumab. It's sometimes referred to as the Sunlight regimen based on the trial. And you'll see that trifluridine tipiracil and bevacizumab is considered as an option for all sort of molecular subtypes in the post-progression setting, whether we have a RAS mutation or a RAS BRAF wild type. This is an option. So I refer to it as biomarker agnostic. Trifluridine tipiracil is a bit of a clever combination. So trifluridine is the cytotoxic component. I sometimes refer to it as a cousin to 5-fluorouracil. It's an antimetabolite. And tipiracil is an agent that inhibits the degradation of trifluridine. So it's kind of, you're trying to manipulate it in a way that the trifluridine is in the system longer. This is in combination. The Sunlight regimen combines this with bevacizumab. historically known as Avastin, but we know there are many biosimilars currently available. And that is a monoclonal antibody that targets VEGF, vesicular endothelial growth factor. And early on, there were studies that looked at trifluridine tipiracil or TAS-102 or Lonsurf alone in patients who'd exhausted all prior options. And compared to best supportive care, there was a survival benefit that was seen, but it was quite modest. It was about 2-month improvement in overall survival. And subsequently, the Sunlight trial looked at adding bevacizumab to trifluridine tipiracil, even in patients who'd had prior bevacizumab. So like 80% of patients, about 70 to 80% of patients on Sunlight had prior bevacizumab. And it demonstrated that continuing the addition of bevacizumab to trifluridine tipiracil now extended survival by an additional 3 months to what was seen with trifluridine tipiracil alone. And that has led to the approval of this regimen from a publicly funded standpoint in Canada. It's now available in most, if not all, jurisdictions in Canada. Because trifluridine tipiracil is a cytotoxic, it is a chemo backbone, it does have sort of the typical, we worry about counts. So reduction in white count is a common side effect that has to be managed and monitored for. The next biomarker agnostic option, so an option that has become available irrespective of molecular subtype in pretreated refractory metastatic colorectal cancer, is fruquintinib. This is probably the newest new medication, a new agent on the block approved within the last 2 years. And fruquintinib is not a chemotherapy drug. But it is focusing on a target we've heard about before called VEGF. So it is an oral inhibitor of VEGF, and it's quite a potent VEGF inhibitor. It inhibits all 3 VEGF receptors. And we know from the history of studies that have looked at other VEGF inhibitors like bevacizumab, like ramucirumab, like aflibercept, that VEGF is an important target in colorectal cancer. Fruquintinib has been studied in 2 large randomized phase 3 trials, sort of the standard of evidence that's required for us to change standard of care. One was initially done in China called the FRESCO trial, and then the one that led to its approval around the world was the FRESCO-2 trial, a global phase 3 trial, similar design, comparing to what we saw earlier with the TAS-102 data, comparing best supportive care. So the standard of care for a situation where someone has exhausted all known available treatment options to fruquintinib. I'll highlight that for the patients on FRESCO-2, you'll see that many of these patients had already received TAS-102 or trifluridine tipiracil and had also received regorafenib, another tyrosine kinase inhibitor in this space, and about 40% had received both. So a heavily pretreated patient population. And in both FRESCO and FRESCO-2, there was a survival benefit that was seen with fruquintinib versus best supportive care, a 2.5-month difference in median overall survival with a range around that. And that has led to the approval for fruquintinib, and now the publicly funded availability in Canada for fruquintinib in the first lines in this refractory setting. And then, there are some biomarker-directed options that I'm not going to spend too much time talking about because they're currently not available in Canada, but certainly of interest and something where if a clinical trial is available or there's an option potentially to consider an unfunded treatment, these discussions do come up. The first is HER2 directed treatment. So HER2 is another molecular target. It is observed typically in about 3 to 5% of patients with colorectal cancer. And it's seen in other types of cancers as well as a driver. So it originally was identified in breast cancer. So we know that in that situation, targeting HER2 with HER2 inhibitors, whether they're antibodies or small molecule inhibitors, has been a very effective strategy. They're seen in gastric cancers or esophageal and gastric cancers, and similarly, targeting HER2 has been shown to be helpful. So When observed in colorectal cancer, of course, the question was also, can we use HER2-directed therapies? And there have been sort of probably two leading contenders or strategies that have emerged. One is trastuzumab tucatinib. Trastuzumab is an antibody, a monoclonal antibody targeting HER2. Tucatinib is a tyrosine kinase inhibitor, what we call a small molecule inhibitor. So that combination in phase 2 studies has been shown to be effective in terms of improving the likelihood of response in patients with pretreated HER2-positive metastatic colorectal cancer. And the second one is trastuzumab deruxtecan, which is something called an antibody drug conjugate. So it combines this HER2 antibody with a cytotoxic component. Sometimes it's referred to as a payload. And trastuzumab deruxtecan, also in phase 2 data, has demonstrated an improvement, no, it's not an improvement because it's not comparative, but has demonstrated some promising response rate data in HER2-positive metastatic colorectal cancer. What we are waiting for in Canada for approval, while these are on sort of guidelines for consideration, are the randomized phase 3 trials that will confirm whether this can change standard of care. And then the other biomarker sort of directed option in this space is this really rapidly evolving space of RAS targeted treatment. So I mentioned earlier that right now, the presence of a RAS mutation typically means that we cannot use an EGFR inhibitor. It's not going to be helpful. But we know there are many subtypes of RAS mutations, and historically, RAS has been very difficult to target as a druggable target. But there has again been recent data showing that there are certain subtypes where maybe this can be a successful approach. And the first on the market is a G12C inhibitor. G12C mutations in RAS mutated metastatic colorectal cancer are about 7% of all RAS mutations, so uncommon. But there are two drugs, adagrasib and sotorasib, when combined with an EGFR inhibitor, have demonstrated very encouraging response rate and progression-free survival data. This is not currently a funded option in Canada. Perhaps of greater interest is that there are now in studies pan-RAS inhibitors. So, there are studies looking at G12C, G12D, G13D, but probably from a bigger lens, pan-RAS inhibitors, which are initially being studied in cancers where RAS mutations are more common, things like pancreatic cancer and lung cancer, but certainly colorectal cancer will be studied in that space as well. And then I want to make sure I leave time for questions, but anything else, like what else beyond what we've talked about in terms of where there is guideline recommendations and phase 2 data and what is funded in Canada. So I wanted to just spend a minute or so to talk about a study that was just reported about 6 months ago at a meeting, and this very recently been published, called the Stellar 303 study, again in this space of heavily pretreated metastatic colorectal cancer. And it was noteworthy because one of the questions I probably get asked most often is immunotherapy an option? And as I mentioned earlier, that right now, from what we know, the only setting in which immunotherapy has been shown to be helpful for the treatment of colorectal cancer has been those patients with deficient mismatch repair disease, which is a small proportion of patients, right? In stage 4 disease, about 5% of patients. And so what the heavy research focus has been on is, can we exploit immunotherapy for those 95% of patients with metastatic colorectal cancer who have what we call proficient mismatch repair, who do not have MSI-high or dMMR disease. And so this trial was trying to look at the use of atezolizumab, which is a PD-L1 immunotherapy, an immune checkpoint inhibitor, with zanzalintinib, which is a multi-targeted small molecule, a tyrosine kinase inhibitor, including targeting targets like VEGF that we've talked about earlier, versus regorafenib, which was chosen as the standard of care in refractory disease for this trial. And patients were randomized in a 1-to-1 fashion. They had to have been pre-treated and no longer benefiting from the options listed there. So 5-FU irinotecan, oxaliplatin, an EGFR inhibitor if eligible, and a BRAF inhibitor if eligible. And so this trial was both kind of in like somewhat disappointing, but still important in terms of like what's happening in the space. So it did demonstrate a statistically significant improvement in overall survival. Um, but when compared to regorafenib, but it was a very small improvement. So the median improvement in overall survival was about 6 weeks. The other concern about this trial was that the standard of care that was used was regorafenib, but in 2025, when the study was reported, the standard of care has now become sunlight. And in sunlight, which is the trifluridine, tiprazole, and bevacizumab, the median overall survival in that trial was 10 and a half months. So the question was really if this was compared to a appropriate standard of care, would we really have seen that benefit? But it speaks to just the hope that we will find something that can leverage immune therapy for the majority of our patients with colorectal cancer. The other concern with the regimen was the side effects, and I don't know if you've seen these kinds of slides before, but on your right is this summary of treatment-related adverse events, and this is kind of a figure, an illustrative way of showing what the proportions of side effects are, comparing in pink the experimental arm, zanzalintinib and atezo, to regorafenib. And regorafenib is not an easy drug, but if you just look at how much color there is on the zanza and atezo side, you realize that this was also a regimen associated with a lot of side effects, which also makes people nervous. So I don't think anyone believes this is going to lead to any kind of an approval or change in care, but it's a first step towards maybe trying to better understand who are those patients who may benefit from immune therapy. And then finally, I wanted to highlight a trial that is currently open in Canada, led by Dr. Jonathan Laurie, who is in my group at BC Cancer in Vancouver, called the Batman trial. It's being led by the Canadian Cancer Trials Group, which I have the honor of chairing the GI disease site. And the numeric code is CO33. So this trial is kind of similar design to what we heard about from the Stellar trial. So this is patients with advanced colorectal cancer who have now are no longer benefiting from available treatments, where the true standard of care approach would be a transition to best supportive care. And they're being randomized to a standard of care versus an experimental arm that includes a novel immunotherapy combination that's sometimes referred to as BOTS-BAL. Again, like a PD-1 CTLA-4 combination, sort of a cousin to nivolumab, ipilimumab that I was talking about earlier. But the CTLA-4 inhibitor here, the botensilimab, is a kind of an enhanced CTLA-4 inhibitor, and there have been some smaller phase 2 studies with this BOT-BAL combination in proficient mismatch repair metastatic colorectal cancer that have been quite promising. And so that has led to a randomized phase 3 trial, which is what is going to be needed for this to become an approved option potentially in proficient mismatch repair metastatic colorectal cancer. This trial is being done in Canada and soon to be opened in Australia as well as France. So a multinational effort, and the primary endpoint or primary goal is to see if immune therapy with this combination can improve survival. So I think, when we think about sort of the management of metastatic colorectal cancer in 2026, we recognize that that biomarker testing is foundational, and I think it's very appropriate that was the discussion before this talk to really talk about that landscape. Precision oncology is really defined as really tailoring the right treatment for the right patient based on their tumor's molecular profile, the tumor's DNA, and that's really where things are continuing to move forward in metastatic colorectal cancer that is leading to sort of a translation in better outcomes for our patients. At the end of the day, as many algorithms as you can see, or as many guidelines as you can kind of digest, at the end of the day, this is a shared decision-making process where the treatment choice is going to be dictated by the preference of the patient in terms of what are their goals and what are they willing to accept in terms of trade-offs, what is important to them, and that patient lens is is becoming more nuanced and more the need for greater support to navigate these really hard decisions that we have to make. I know you've heard this in discussions before, but particularly as we're seeing a younger population of patients navigating metastatic colorectal cancer, there's even more um, weight on what are those preferences and how do we balance what the needs are, because we know they're different in different phases of our life. Um, and so the optimal sequencing strategy, I said before, I don't like lines because it seems to imply you're going to go from first line to second line to third line, and it's not that rigid. We need some clinical flexibility to individualize the sequencing strategy, but at the end of the day, the goal is really to ensure that we have availed all proven effective treatments in a way that will offer the best benefit for a particular, an individual patient. Access to molecular profiling is clearly important, and then considering clinical trials whenever available is also very important. And so I thank you very much for your attention, and happy to take any questions if we have time.
Thank you so much for being with us here today, Dr. Gill, and for such an informative presentation. You're always so engaging and knowledgeable. Please know we do appreciate that.
Thank you.
Our silent viewers, please do head back to the lobby to join the next session, which will be at 12 p.m. Eastern Standard Time after a little additional health break before we join Dr. Medvedev. Quick reminder, the post-lunch sessions will have a different link than the one we used this morning, so just to keep that top of mind. And coaches can now head backstage for our question period, and we will see everybody again at 12 p.m.